From Faith Forward Media, this is Healthcare Musings. I'm Dr. Hassaballa. Welcome to Healthcare Musings, everybody. Happy to have you with me. Okay, so another major comorbid condition, MCC, that is frequently targeted by payers and their third-party designees is acute respiratory failure or acute hypoxic respiratory failure. They target this all the time because, again, say you have someone who comes in with a pneumonia and they're hypoxic, their oxygen level is low. That's a higher severity of illness than someone who comes in with a pneumonia that has a normal oxygen. And so higher severity of illness gets more money reimbursed, right? Because more complex care costs more. And so the hospital gets more. And parties will go back, payers and their third-party designees will go back and then deny or dispute the presence of acute hypoxemic respiratory failure and then say, we overpaid you by $5,000, you owe us the money. Okay, they do this all the time, and they're going to continue to do this. And a lot of the times when I look at the denial letters, because I deal with these appeals almost exclusively, when I look at the denial letters, they'll say, not only is there no evidence of a low oxygen, but they'll also say there has to be respiratory distress, there has to be dyspnea, there has to be tachypnea, there has to be paradoxical motion, there has to be use of accessory muscles, there have to be use of non-invasive mechanical ventilation, all these things in addition to the low oxygen. And I'm here to tell you, no, that's actually absolutely not true. I'm not only a physician advisor, I'm a pulmonologist, and this is what I do on a daily basis. It's what I literally, pun intended, live and breathe. Okay? Acute hypoxic respiratory failure is defined as either a PO2, a partial pressure of oxygen in the blood less than 60, or a SpO2, oxyhemoglobin less than 90% on room air, or a PO2 over FiO2 ratio of less than or equal to 300. And what a PO2 over FiO2 ratio is your partial pressure of oxygen, and you divide that by the fraction of inspired oxygen. So that number, if it's less than or equal to 300, that's also hypoxic respiratory failure. That's it, period. That has nothing to do with symptoms. There's no need for dyspnea. There's no need for respiratory distress. There's no need for any of those things whatsoever. No, zero, none. Okay. Now, when you're hypoxic, if you have a pneumonia and your lung spaces are filled with white cells and fluid and edema and everything, you're going to be short of breath. Yeah. When your oxygen level goes down, you're going to be short of breath. You may have respiratory distress. You may have use of accessory muscles. You may need to use non-invasive mechanical ventilation. All of that is true. It has nothing to do with the definition of hypoxic respiratory failure. All of these symptoms and signs are consequences of the hypoxia, not a equal definition. Okay. Don't let either the payer or the auditors get away with this, right? They always say, not only is there no, you have to have oxygen, low oxygen, you also have to have all of these signs and symptoms. Nope, nope, nope. If you have an oxygen saturation of less than 90%, either on room air or on supplemental oxygen, or if you have a PO2 less than 60, okay, or if you have a PF ratio less than 300, that's hypoxic respiratory failure. Now, the PF ratio requires a blood gas, an arterial blood gas, not a venous blood gas, an arterial blood gas. And a lot of times people don't do that because it hurts and you have to stick the artery and it's more complicated and it takes longer than getting a venous blood gas. And you cannot get and measure hypoxic respiratory failure from a venous blood gas. I don't know why a lot of people do this. Okay, you're checking the venous blood before it gets to the lungs and making some sort of decision about how the lungs are working. It's not. You have to get the blood that's gone through the lungs, and that's arterial blood. Okay, so that's a whole separate topic. So if you don't have an arterial blood gas, you can't get the PF ratio. Okay? At the same time, the symptoms have nothing to do with the definition. Hypoxic respiratory failure is either a PO2 less than 60, an SpO2 less than 90, or a PF ratio less than 300. Period. Full stop. And now, what I see a lot of times is that somebody who's short of breath comes in, okay, and their saturation, say 92%. That may be low for them. That may be lower than typical for that patient. It's not technically a respiratory failure. And then so they slap on oxygen, and then they say, and then they code and diagnose acute hypoxic respiratory failure. Not quite. I mean, if I was called on consultation on that patient, I would not agree with the diagnosis of acute respiratory failure as a pulmonologist. Okay. Again, someone may live in the high 90s all the time. And then if they get pneumonia, they go down to maybe 92. That might be clinically significant, that it's starting to affect their oxygenation. That doesn't technically mean that they have hypoxic respiratory failure unless you get a blood gas that demonstrates a PF ratio less than or equal to 300. Absent that, and that's frequently absent, I must say, you cannot then say this is hypoxic respiratory failure. It's not, okay? And slapping oxygen on someone, okay, adding supplemental oxygen does not respiratory failure make, okay? And I see that all the time. And so you have to be fair. It kind of goes both ways, right? Just putting oxygen on someone does not mean that they have hypoxic respiratory failure. I don't even know why. I mean, maybe it makes them feel better, okay, a little bit, but if they're saturating above 90%, okay, especially if they have chronic lung disease, that's fine. They don't necessarily need oxygen from my perspective as a pulmonologist. Still, okay, when these denials come through, they're gonna target these MCCs like respiratory failure, metabolic encephalopathy, which we already talked about, obesity, protein calorie malnutrition, so on and so forth, and they love to target acute hypoxic respiratory failure and then deny it because then they can claim to have overpaid. Again, the symptoms have nothing to do with the definition. The definition is if you have low oxygen on room air or even supplemental oxygen, if they're on 5 liters nasal cannula and they're saturating 85%, that's acute hypoxic respiratory failure, period. Okay? That's the definition. And if that's present, you should document that. And it has to be present, okay? Not a 91% and you put them on 2 liters. That's not hypoxic respiratory failure. But someone who has real low oxygen level does have hypoxic respiratory failure. Make sure we know that, and then and if it's present, accurately document it and explain where that there's. If they and clearly document that, and then the chart will be very strong on appeal when you have clear documentation of a low oxygen level. Thanks so much, guys, for your time and attention. And until next time, we'll see you on Healthcare Musings. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.